Si podemos regresar un poquito en dónde está el...
Can we go back now to see the connection between services and insurance? When you talked, Julio, about the services being provided because of the underinsurance condition, but also because of the services which are not insured. This year, if everything is okay between us and now we're going to receive for the first time in California a group of Mexican physicians who are going to work at the federal clinics in California. They are with their medical license of Mexico without having a U.S. medical license under a special program for 3 years. And then they will go back in order to try to treat the Latino population in this type of clinics. These clinics, together with telemedicine, these patients might have access to physicians in Mexico with the medical insurance of Seguro Popular or IMSS, because this might pay for the physician in Mexico for what they are doing with the patient in California. The descriptions have concentrated on what might happen now, what could happen, or what type of flexibility do we need in order to be able to move forward. I don't know if you want to go first to the insurance arena. Well, this is a very complicated topic. The health system on both sides of the border is highly fragmented into institutions and populations in different geographic situations. The U.S. system has its own licenses and rules for each of the states, so one of the problems of portability is the huge amount of regulations which exist for a Mexican institution to sell an insurance in the United States. It has to be done first by state, and it has to abide by a series of regulations. So in the case of 1996, this was done through the consulate, where strictly speaking, we were not selling an insurance in the U.S. territory. Now, telemedicine that was described, even in the United States, telemedicine has strong regulations to provide services from one state to another. There is a great opportunity with e-commerce now that they are digitizing imagery and medical files, yes, and e-files. I mean, everything is so revolutionized that regulations won't be able to keep up with the new technologies. One of the great challenges and opportunities is try to start understanding how regulations could adjust to the new migration realities, technological realities, and needs of coverage of this new population that is so portable. We were talking about 1 million U.S. citizens living in Mexico. All of them have to come back first. Most of them have their active coverages of Medicare Part A and Part B, because when they have a non-acute event, they go back to the United States to pay the case at 5 times the price they could have paid at San Miguel Allende. This is some of the rigid elements that will be eliminated by the economic rationale, as it has been solved in Europe and in other markets. That is to say, the integration has to happen sooner or later because the economic rationale is there. First, I think that what you have just said is wonderful. This is the type of flexibility needed. California is a leading state and the most innovative state in flexibilizing. This is the only U.S. state where an insurance company in California, in fact, they can pay for services provided in Mexico. And this is used not only cost-wise, but also because of the proximity or cultural accessibility of services. So there are some insurance companies in California, and this is the only of the 50 states that allows that to happen, that they sell you a much cheaper premium program if you use the services across the border. A lot of people prefer that not only because of the cost, but also because of the cultural compatibility. So what you are describing now among the universities would be a huge step forward. I also recall a great innovation, and Roberto Tapia sitting here was one of the leaders, the creation of binational health weeks, where we were able to have a coordinated benefit, and health windows in all the U.S. consulates were created as a result of this. So this would be something very important now. It is a fact that where we have the greatest opportunity is something that under this debate, under this divided rhetoric that we have seen in Mexico. I don't know if you recall, but in the case of the U.S. population, most of the people that I have access to, they don't have, at least say that Mexico is the place where most of the U.S. citizens that live abroad live in Mexico, more than 1 million people. There is no other country where so many U.S. citizens live than in Mexico. And under a logical scheme, the proposal made by David Warner of the University of Texas, which shows that is economic rationale, is to allow the reimbursement through Medicare, what they were saying about German citizens who moved to Spain, and by doing so, the German health system saves money. In any health system, the payment for retired people is the highest cost. That would be so logical. In Mexico, there is a group which is called Americans for Medicare in Mexico. Yes, there is an organization of U.S. citizens who are promoting this. I mean, there is the Association of American Residents Overseas that are requesting this to happen, but the interests of service providers in the United States are much more powerful, and they have prevented this from happening. This would be a win-win for everybody, and even more so for patients, for things which are not complex, for the Medicare, for the citizens that pay their taxes in the United States, and also for Mexican service providers. The only ones that lose a little bit are the U.S. service providers, but they would win because they would have to become more competitive. This is like a commercial protectionism where these are non-tariff barriers to the trade of services. I am in favor of regulation to protect the rights of patients and the quality of services, but if we do so, there should be free mobility. I hope that more pilot cases like your case are done now. When we talk about Seguro Popular, I'm thinking about all Mexicans who are undocumented, because even though the Affordable Care Act was a huge step forward, there is an omission that I have to criticize that explicitly left us not as part of it, undocumented people in the United States. If the Obamacare moves forward, the United States would be a country where only undocumented migrants would not be insured for medic or for health services, for health care. And this is a right that should not be mediated because of the legal status of the person. This is a great effect. That's why the Seguro Popular introduced another catastrophic insurance to be offered to the Mexicans who cannot have such an insurance in the United States. What is uncovered are the daily activities, which is 85% of the demand. So being able to use community health centers there would be wonderful. I think that we can be creative if we can leave in the past stereotypes, demagogy, and rhetorics. A last final question before opening these two questions. What you are describing now, both the differences in cost of the medical services on both sides of the border, as well as the problems that each state has, also apply for education. When William was talking about Mexican students in the University of California, you were only talking about the students who traveled there to study, but the largest population in the University of California are the Mexican undocumented students who grew in California and who are now studying at the university. And when we talk about the possibility of the use of technology, telemedicine, teleeducation, e-learning. One of the things that I am sure that my president and director will discuss tomorrow has to do with the students of the University of California. If they are expelled from the United States, how can they be received by the UNAM? How can we provide them our services through telecommunications? But this can also open possibilities for more academic exchange. What's your opinion on this? Well, precisely this is what I wanted to say. How can we take advantage of some of these differences? And this relates to the several levels where we find cooperation. And I would like to illustrate this with an example. In the year 2010, I went to a meeting in Pasadena, which is called SACNAX, which is the Society for the Advancement of Chicanos and Americans in Science. And we went there because we needed badly money for an astronomy project in cooperation. The CONACYT, the Arizona colleagues, the University of California, we all went there together. And we thought that by organizing a forum for the motivation and cooperation of the Hispanic community there, that would be a good idea for the Hispanic community to try to excite people in cooperation, and perhaps we could raise some funds. And it was a whole discovery, the activity in itself, because we discovered a channel that seemed to be totally different, because we were talking about institutional cooperation, because that's a different population. There were migrants, second or third generation of migrants, and what they wanted was to open opportunities to make progress in higher education in the United States as a minority. And the disciplines that we represented there, we had a lot of chemists there, a lot of social science, legal protection, due process, science of life, and almost nothing of engineering, physics, mathematics. And this on the one hand. But on the other hand, they were individual and local efforts, not institutional binational representation. This was totally absent. So this was an experience that opened our eyes, the possibilities to new things that we had not considered in the past. These were totally different opportunities, totally different to the scheme that I go there, study, and then I come back. People who are there, and a level of cooperation, shared common culture that could be used for this, and this is one of the highest opportunities that we have there, this orthogonal cooperation, mainly with the people who are now being sent back, and the exchange that you mentioned in the beginning. And this potential reflects that cooperation is a two-way street. And it is not only a two-way street, but it's a two-way street with several tiers. And an institutional initiative like this from UC to Mexico, and with an important participation of the National University, is an ingredient that can help foster and trigger new ways for this type of cooperation. And to close, I just wanted to echo something mentioned by Julio in the beginning. We didn't discuss this before, but it perfectly matches. The academic cooperation and scientific research in social sciences is a self-corrective process. If you say something which makes no sense, somebody will try to check if what you said is right or not. And if you are tested 3 times and you were right, if not, you will have to change your thesis. Now, this relates to the type of problem that we're trying to solve. It is very important to know that this also applies to the definition of the problems that we are trying to solve. This is a self-corrective process too. And if we, as important universities in Mexico and in the United States, namely in California, if we as universities want to solve problems, economic, important demographic, economic, health problems between both countries, well, the authorities of both institutions will lead to a self-corrective process that will try to find these solutions. And this is also a very good example example, a good example that can happen. A situation where a community with self-criticism and with a certain authority may state, these are the things which we believe important and that we believe that have to be tackled. I just wanted to add some things as experts in the migration and education processes and what we have learned in the process of the people who have returned with regard to education. When we talk about the population that we share and the population that we have to take advantage of, we're talking about young people, the dreamers, and also the ones that go to the States and then come back to Mexico. In demography, we say that we lend the demographic bonus to the United States, and this is a way to recover that part of the demographic bonus that we lend to the United States. But I also want to be critical and say that there is a great challenge for the Mexican context. First, the Mexican educational system is not flexible, so it is not ready to receive necessarily foreign students. For example, minors in elementary school and secondary school, we tried to do that in 2011, and it took us 5 years to remove the necessity of a stamp in the birth certificates. There are other leadership initiatives like the Nuisa UNAM, because you help them. In the case of higher education institutions, they have more autonomy of action. Now, my second concern has to do with the integration process in the schooling system itself. I say a lot that we have to be highly logical with our migration discourse abroad in Mexico. We have found a lot of discrimination to Mexicans coming from the United States in their insertion to school context, and we have to make people aware there. We have to work hard with people at schools, with teachers, with other students, and be able to generate that proximity. I am very optimistic because I believe this is an excellent initiative. We also have to push for harder and move in advance to any negative consequence that can be derived from the arrival of new migrants, of the people who are forced to come back to Mexico or those who decide to come back to Mexico. Well, I would like to invite the audience to take the floor. Andrea, do we have a microphone? Vale Martin. While we have the Q&A microphone, I would like to say that a lot of people sell in the United States, what I have seen, mostly are the students that I have at Berkeley. Dreamers, the DACA, the dreamers, Mexican dreamers, who for the first time since they left Mexico when they were 2 years old had the intention to come back to Mexico as part of their education to the University of California, and they can do that no longer because what is an irony is that they cannot go to Mexico with the current situation in the United States. It's so sad, people are so sad. Andrea, please. I would like to ask a question, both to Eduardo and Dr. Frank, on insurances and portability. Here we are talking about the situation of Mexico and the United States and Mexican in the United States and Mexico, but we also have the people from Central America. There are very poor countries in Central America that are being left outside. Right now, at the medical services, we are receiving people in humanitarian crisis, basically from Central America because of violence at the border. That is, they are living hell in life with this migration. And the decision of Seguro Popular has been to limit medical services to 90 days, including antiretrovirals in pregnant women, tuberculosis vaccines, for example. So this suspension of medical services after 90 days in a mobile population that goes between Mexico and the United States is an element that will for sure affect health problems, mainly with public health, tuberculosis, influenza, and others. I would like to note on your opinion, which, in addition to having the opportunity of matching the services, according to you, which should be our reaction in both countries regarding this Central American migration and regarding this humanitarian crisis, which is moving from Central America to the United States. Well, I would like to make two comments first. Mexico must, as stated in public policies, but Mexico in fact must be totally coherent. If we defend the rights of Mexican migrants in the United States, we have to be as coherent and active and passionate for the defense of the rights of Central American migrants coming to Mexico. In fact, an important part of the cooperation between Mexico and the United States has to do with Central American migration. If we put at risk cooperation in these broader topics that go beyond trade, we might have there some negative repercussions. I do underwrite the fundamental value that access to healthcare is a human right. There are no other considerations. This has nothing to do with your legal status, with religion, with your nationality. I mean, this is an inherent right. So any person who is at any territory in any country has the right to have access to health care. I didn't know this 90-day rule. We have to fight these rules. These are bureaucratic rules, sometimes imposed by budgetary constraints, I know, but this has to be approached with the lower house and at Congress to see the implications. In addition to the violation to human rights, the counterproducing effect of having people in your national territory and suspending treatment to an infectious disease, putting at risk everybody, including the Mexican citizens. The same arguments that we are posing to talk in favor of the protection of Mexican migrants in the United States. Very good comment. We must not forget that there is the other side to migration. Mexico also receives migrants, and this is part of its work. The last comment that I would make in terms of migration and health, this is a very complex topic, and one of the most complex topics is the provision of services to mobile populations. Migrants, journeymen, farmers, all the paradigm of healthcare forces stationary or fixed services with population that moves to receive health services in a building or establishment. But when you have a mobile population, you have to match that with the nature of those services. You must achieve coordination, mainly with populations like agricultural workers that have mobility, well-known mobility patterns, where a good health system gets adapted to those schemes. So always healthcare services to mobile populations have faced that challenge. They don't match the paradigm of medical care provision. And telemedicine could be very useful there, but we have to change the model, and we have to devise, I don't know if it's coordination formulas or other types of formulas that allowed us to do so. When I worked at the ministry, we developed very interesting programs to treat infectious diseases like tuberculosis with a binational tuberculosis card that allow us to have that coordination, because patients with tuberculosis and the level of mobility that you explained move from one country to the other, and there was an effective coordination of service providers. I think that we have to be more flexible in order to take care of the needs of populations in movement.
We have a lot to say, but it is a topic we are looking up north and very little down south. So we're talking about Mexican doctors that are up there. In Mexico, we have Central American and South American doctors that have the same integration needs. We have to separate this topic of health with external situations, the infections part. We have to take care of them because of epidemiological control. But what we need is to make this mirror agreements with the northern border and make sure that the Central American countries and those that are having relationship with Mexico. Inga Davila has been working very many years. The Ministry of Health has done a lot. The agenda has many things included, but thank you. I want to thank the panel. First of all, thank you. A warm hand for the panel. Second, I want to thank Alan Brand. He went out. He is in between quotes the owner of the house. He's a director of the California House, and all the team that did the work to assemble this event. Many people are in the back. Some couldn't come because they're at DACAS. And I would like to invite my chief, the President of California, and Dr. Graue, the Dean of UNAM. Thank you so much. Thanks to their vision, their support on both sides that we have this initiative of UC Mexico. We didn't know that what happened in November actually passed, but this gives us a possibility of continuing with a platform of innovating activities and events. Thank you.